think sort of starting in the neoadjuvant space with DB11, we are seeing higher pathologic complete response rates with incorporation of T-DXd in the neoadjuvant space. It's interesting in terms of how to sequence the T-DXd, taxane, trastuzumab, pertuzumab. I know that's one of the questions we've been thinking about and would love to hear your thoughts as well, compared to the comparator arm, which is a little different than what I think we traditionally give in the United States. I think traditionally I would give a taxane, platinum, trastuzumab, pertuzumab, compared to the control arm, which was an anthracycline-containing arm. And then, of course, there was an arm that was the T-DXd alone, 8 cycles, which was stopped early due to not wanting to move forward based on activity. So having these 3 arms, really the 2 arms to compare, of course, the pathologic complete response rates were higher in the T-DXd THP arm. And when I think back historically, one of the things that I really want my patients to achieve is a pathologic complete response. We have decades of data saying that achieving a pathologic complete response does confer a better outcome. So, I don't know that we're at a one-size-fits-all in breast medical oncology across the board anymore. But for patients who are coming in with higher burden disease, we have overall their performance status is very good. And we want to really bring them to pathologic complete response. I think we are in a place now where T-DXd is part of our neoadjuvant regimen.
Right.
Yeah.
And also the advantage of having only 4 cycles of T-DXd with much less rates of ILD it's an attractive strategy to utilize. Then thinking about using it in the post-neoadjuvant setting if the patient has residual disease, where we are facing 14 cycles with much higher rates of ILD. So that's a concern as well. And that's also another reason to consider using it up front to get the best response we can and get the high rates of pCR, so that our patients don't have to face the residual disease scenario.
Could not agree more. I mean, I think the biggest trade-off for T-DXd across all of our stages is the concern for ILD, interstitial lung disease. And I think we've gotten a lot better as a breast medical oncology community about how to monitor our patients and recognize it early and try to determine a grade 1 over a grade 2 where we have permanent discontinuation. But I do agree, having the 4 cycles as opposed to 14 does show lower rates of ILD, which is very attractive. And I think in most cases, and I'd be curious to hear what you do at your institution, we have been incorporating an every 6-week non-contrasted CT of the chest during the course of T-DXd in the curative-intent setting. And in the first year, in the metastatic setting, and we'll talk a little bit about that. But I'm curious what you do at your institution and what barriers you might have seen in trying to maintain that very strict ILD monitoring.
Right. I think that's going to be an ongoing problem, especially in the community settings where they may not be able to get frequent scans and insurance barriers. Those could become more of a practical challenges as we start to implement this data in our real world situation. At our institution, there's a little bit of a varying practice between different providers. Some do every 6 weeks, some do every 9 weeks. First when we had the Enhertu metastatic studies, that was one of the top questions. But I think now most of them are agreeing in the every 9 weeks in the metastatic setting. But in the early stage, I think we have to be even more cautious because, again, these are patients. We are curing them from disease.